You are currently the only person in this conference.
Well, hello there. I hope everybody is doing well today. Today, we're going to talk a little bit about the high risk pregnancy. What's interesting when we talk about the high risk pregnancy, we're really talking about two different types of issues. We have the one type that is with those that have pre existing conditions, such as maybe asthma, lupus, celiac disease, GI issues, pulmonary issues, cardiac issues, all those issues that they acquired prior to pregnancy, and now they choose to become pregnant. So basically, with a lot of those issues, which are a lot of your med surge issues that you've already discussed, how we manage those is we manage that condition during pregnancy. So, for instance, maybe if they had some kind of a mental issue, we try to manage it before pregnancy and see if the drugs that they're on are compatible with pregnancy, and maybe try to get them off drugs they don't need to be on, those types of things. So preconception care is extremely important on those with pre-existing conditions, meaning getting healthy or getting the information they need prior to pregnancy. But a lot of those conditions just can be managed by managing their medication, if they have flare-ups, those types of things. But a lot of times those conditions are kind of like conditions when they're pregnant, they are like maybe on steroids because it causes more of an issue, like on cardiac conditions because of the increased work on the heart, those types of things. And then there's the others, high risk things that are unique to pregnancy, like gestational diabetes, gestational hypertension, those types of things. So when we talk about high-risk pregnancy, there's a lot of issues that we're talking about. A lot of people think when we talk about OB that we're really not, talking about the medical stuff that you've learned about already. But believe me, all those conditions, obesity, all those things you talked about in med-surg, a lot of those conditions, people then get pregnant with those same conditions, which causes careful monitoring. So we're going to look at some risk factors and some of those pregnancies that are complicated by health alterations, and describe some care for them, and collaborative care too for the pregnant client experiencing complications. So when we look at high-risk pregnancies with gestational conditions, that's during the pregnancy, that is the occurrence in pregnancy which puts both mom and fetus as a risk. And I've already done the PowerPoint on hypertension, but it also includes hyperemesis, hemorrhagic complications, and trauma. And that's what we're going to concentrate on initially. Whenever we talk about high-risk pregnancies, we always want to identify those that are high risk. And so we kind of do that either preconception care before the patient becomes pregnant, or actually in prenatal care. Some of the biophysical risk factors would include their genetic makeup, nutritional. We have people that are obese. We also have people that are anorexic that get pregnant, and some of their medical risk factors as well. And then we have the psychosocial risks, which include emotional distress, support, relationships, and those types of things. Socio-demographic risks, lack of prenatal care, low income, ethnicity, and then the environmental factors, what they're exposed to as far as environmental chemicals, radiation, etc. So we kind of take an assessment, and then we determine basically which of our patients or our population that are high risk, and we try to manage those. Some of the testing that we'll do for our high-risk patients is one of the easiest ones, and we do this for all our patients, is we tell them to be aware of fetal movement. Most patients will feel the baby move between 16 and 20 weeks gestation. If they've already had a baby, it's probably going to be closer to 16 weeks. And if it's their first, it may be closer to 20 weeks. Once they feel the baby move, they're going to kind of feel the norm for their baby. So a lot of times we'll make sure that they are aware of their norm, and if there's anything different, like less, then they should contact their health care provider. And sometimes we give them a fetal movement card, which makes them lie down and be aware of fetal movement and count fetal movements. And if they don't feel it or they're worried about it, they should drink something cold and maybe eat something really sugary and maybe play around with the tummy a while and put something loud noise or something to wake up the baby and see if the baby moves. Because if a baby is doing fine, it will react to some of those, the cold water or sugary food going in or the fetal move for you moving your tummy or the loud noise. So we have patients, we educate them to be well aware of baby movement. We also have lots of ultrasounds that we do. We do ultrasounds early on in pregnancy to identify any risk factors. There's a big ultrasound that people look forward to between 16 and 20 weeks gestation, and that's usually when they find out the sex of their baby, but they also are looking for any kinds of genetic issues or problems with the baby. Those people that have hypertension disorders particularly, we're really concerned with, is the baby getting enough flow from the placenta to the baby? And so that sometimes we use the Doppler flow analysis for that, which kind of looks to make sure that the baby is getting an adequate flow. So that would be for maybe maternal hypertension, diabetes, intrauterine growth restriction, or multiple fetus, just analyzing the blood flow to the baby. The amniotic fluid index is a test. It's an ultrasound test where they measure a pocket of fluid to make sure that the baby has enough amniotic fluid. We know that babies cannot survive with no amniotic fluid, and they also have problems if there's too much, and we call that oligo and also polyhydramnios. On the AFI, which is an ultrasound, a normal AFI would be somewhere between 5 and 25, showing that the baby has enough fluid. And I will not make you responsible for knowing, particularly like how much milliliters or anything that is. Just know that, we will be measuring that amniotic fluid index on some patients to know that they have enough for fetal well-being. The biophysical profile is another test that we do for fetal well-being, particularly like on our diabetics or anybody who's at high risk towards the end. And that's an ultrasound that checks out the amniotic fluid to make sure that there's enough. They check out the fetal heart rate, make sure that there's movement, and sometimes that includes a non-stress test where we put the patients on the monitor. But they're looking at fetal movement with that and the heart rate going up. And they can tell that with ultrasound. They're looking at fetal tone and fetal breathing movements as well in that ultrasound. And that a good score on a biophysical profile is a 10, or that's a perfect score. So anywhere between a 7 and 10 on a biophysical profile usually means that baby is doing okay. A non-stress test is basically when you put a patient on the monitor and you're looking for 2 or more fetal heart rate decelerations. Remember, we talked about the 15 beats per minute. 15 by 15, it goes up by 15 beats, at least for 15 seconds. Or more with fetal movement in a 20-minute period is reactive. So that would be basically looking at a 20-minute strip, making sure that baby is moving a couple times and the baby's heart rate goes up at least 15 beats. And then we have a contraction stress test, which we really don't use that often anymore. And that's when we try to give a patient a contraction to see how well the baby tolerates the stress of a contraction. And back in the day, we used to do it by having patients stimulate their breasts with a washcloth, causing a contraction and seeing if baby tolerated that by an acceleration. And sometimes they would have decelerations. And sometimes we'd give them Pitocin. But we do not see that test too much being used for fetal well-being because most will want to go with a non-stress test and the biophysical profile for fetal well-being. So there's lots of tests that we can do to monitor the baby inside to make sure baby is doing okay. These tests that we can do include ultrasounds, which include the Doppler flow analysis, amniotic fluid index, biophysical profile. We can also do the non-stress test, and we can have patients check on their fetal well-being by fetal movement. Hyperemesis then can actually put a patient at risk as well, because we also know that nausea and vomiting may complicate up to 80% of pregnancies. And if I say 80% of pregnancies, I'm talking about the majority of pregnancies will have some problem with hyperemesis. Normally, it's going to occur early on in pregnancy, and usually by 20 weeks, it's pretty resolved, if not before. Why? Well, we're not really sure why, but it may involve some relaxation of the smooth muscle of the stomach or increasing hormone levels of estrogen, progesterone, and HCG. But we do know that occurs, and it can be quite problematic in a lot of our patients. Most of them, it will resolve. But there are some people that come in with a really bad case. They can't keep anything down. In fact, it's the second most common reason for hospitalization during pregnancy in the United States. They come in with electrolyte imbalances, nutritional deficiencies, and it is when it is an electrolyte imbalance and nutritional deficiencies, we call it hyperemesis gravidarum. There could be weight loss, dehydration, a decreased blood pressure, increased pulse rate, and poor skin turgor. They just can't keep liquids or food down. Of course, as nurses, when they come in, we attain their weight, their vital signs. We're probably going to take a urinalysis and electrolytes to determine what course of treatment that they will get. Most of the time, though, they're going to get IV therapy to replace fluids. They also may get some vitamin B6, Zofran for the nausea, and a lot of patients are on Zofran, sometimes the majority of their pregnancy. And then we will progress diet as tolerated. Now, sometimes nursing care could include the IV therapy and antiemetics, and sometimes they will actually need some potassium or electrolytes. But sometimes we encourage these same patients, to have small, frequent amount of foods, avoid skipping meals, and that's why you'll see pregnant women eating every couple of hours, mainly sometimes dry, starchy foods upon awakening. You've heard of women keeping saltine crackers nearby. And avoid excessive fluids when they are nauseated, because they're probably just going to throw it up. Some people find acupressure can resolve some of their nausea as well. Vitamin B6 has been beneficial. We also encourage a high-protein snack at bedtime that has been known to be helpful. Ginger, the essential oil, can be beneficial. Sometimes they can put on a drop on a cotton ball of the essential oil ginger and put it in their pillowcase. There's also all kinds of ginger cookies, ginger snaps, ginger everything, ginger ale, ginger tea, hot, cold, whatever helps them. But ginger is supposed to be very, very good for nausea and vomiting for these pregnant patients, and it's rather safe. Sometimes all that people can keep down is the sweet and salty, like, the peanuts and M&Ms. And if that's all that they can keep down, then we say keep on, just keep eating whatever you can keep down. We encourage them to get a breath of fresh air, which sometimes helps with nausea. Sometimes if you brush your teeth immediately after eating, it causes nausea, so we encourage them not to brush their teeth after eating. Salty foods seem to be beneficial for nausea. Herbal teas in addition to the ginger tea. Interesting enough, dairy products sometimes helps. They may stay down easier than some other foods. And popsicles help with dehydration and the dry mouth, and just is very soothing to those patients as well. So now we're going to talk a little bit about the antepartum hemorrhagic disorders. Interesting enough, we already talked about hemorrhagic disorder in the postpartum patient, which included the postpartum hemorrhage, which had strict protocols, and we talked quite a bit about that. Now we're going to center in on, because a lot of people think that that's the only risk for hemorrhage, but actually we have high risk at the first trimester, which includes miscarriage, ectopic pregnancy, and molar pregnancies, and also in the third trimester, especially with placenta previa and abruption. So we're going to focus on those. A miscarriage, or spontaneous abortion, is a pregnancy that ends before 20 weeks from natural causes. It's usually less than 500 grams, so it's not viable. 10 to 15% of all clinically recognized pregnancies end in miscarriage from what we can find, but we think it might be higher because some people don't come in for help if there's no problems after they've miscarried at home. 80% of these occur before 12 weeks gestation, and at least 50% of them from chromosomal abnormalities. They can do that by testing. A late miscarriage is a second trimester loss, which is between 12 and 20 weeks. And those are extremely hard on our patients. I've had patients deliver babies at 16 weeks, and they actually have to go through the whole labor process. And when they actually deliver, there's actually a very small baby that comes, and the grieving is real. Actually, a lot of times, a lot of these patients are already producing colostrum and will produce milk, but they go home with empty arms. So it can be quite traumatic. This is a perinatal loss. Both a miscarriage and either early on or late can be quite traumatic for our patients. You have to remember when a patient becomes pregnant, even if it was an unplanned pregnancy, they actually get kind of excited and they start planning. And they've already started their dreams and their hopes. And so by the time then they start, then they tell people. So when they lose the baby, it's a great sense of loss to them. And the longer that usually, and it's not always, they will not always say the longer, like even a 16-week, they're going to have more loss than a 12-week gestation baby. It's not always that way because there's a lot of people with infertility issues that when they have a miscarriage, it's a big loss, particularly if it's from IVF, which is extremely costly and has taken a lot of time. So I guess I add that because sometimes we spend so much time talking about the medical aspect, but it's the psychosocial aspect that is extremely hard on our patients. So recurrent is generally defined as 3 or more consecutive losses of miscarriage. And usually after about 2 or 3, we have our patients seek help and find out why. It could be an incompetent cervix. It could be a lack of progesterone or other issues. And so sometimes we can give them help and guidance. When we talk about the spontaneous abortion, we actually label them into 5 different categories. And yes, you will be responsible for knowing these. But if you look at the word, it kind of gives you a clue on what's happening. So let's take a look at this. So a threatened abortion would be, let's say a patient wakes up and she's maybe 12 weeks gestation. She wakes up after sleeping and she notices a little bit of cramping. And when she goes to the bathroom and she wipes after urinating, she notices some blood on the toilet tissue. Now, I can guarantee you blood is not a normal occurrence and it freaks people out when they're pregnant. So let's say she goes into her healthcare provider, or she may even go into the ER. And what they'll do is they'll probably do an ultrasound. And they'll notice that, the baby is still there, the bag of water's intact, the cervix is closed, and she's had a little bit of bleeding. So what it is a threatened abortion, meaning that, they're, to mean that right now it's okay, go home and rest and take it easy, and it might go away, because a lot of times it will go away. And occasionally, though, some of those threatened abortions turn into an inevitable or a complete abortion or whatever. But basically, when we're saying it's threatened, we're meaning, could go either way. But right now, the pregnancy is okay. So rest and keep an eye on it and see if the bleeding and cramping go away. Inevitable is when a patient wakes up and there's some cramping, they notice some blood in the toilet, they go to their healthcare provider or the ER. And what we notice is when we look inside, there's probably a lot of blood, maybe even the bag of water is broken, a lot of cramping. We look by ultrasound and we can tell that basically it's inevitable. The patient is losing the baby. It's in the process. It is happening. She is losing the baby. The next one would be an incomplete. An incomplete one would be maybe a patient wakes up in the morning. She notices cramping and bleeding, and she goes to the bathroom. And then she notices that she's lost the baby, maybe even in the toilet. but she continues to bleed. And this is where patients can actually bleed to death. So she goes to her healthcare provider, who may even send her to the emergency room, because what has happened is she's lost her baby, but a piece of the placenta or the pregnancy has been left behind, so the patient will continue to bleed. So those patients, the course of action most likely will be a D&C, where they go in and they scrape or suction out the contents of the pregnancy so the patient will stop bleeding. Those people are at extreme risk for hemorrhage. And then you've got the complete. And the complete abortion is, let's say a patient is at home, sleeping, she wakes up, she goes to the bathroom, she realizes she's cramping, she's bleeding, and she's lost her baby, and she can actually see the contents of the toilet. And she doesn't bleed anymore, so everything has come out. And so the pregnancy is no longer there, but she's got no complications. So what happens in these cases is sometimes they'll seek medical care, but even if they didn't, it resolves itself. And so sometimes those are the ones that don't get reported because they lose the baby, but everything came out, and so the bleeding and cramping stops. It's completely taken care of. And the last one is the missed abortion. And that's the patient who may be 12 weeks, all excited because today she's going to the doctor. She brings her husband. They're going to maybe tape record the baby's heartbeat. And when they get to the doctor's office, the doctors notice that there is no heartbeat, and they do an ultrasound, and they notice that the baby does not have a heartbeat, that the baby has died inside, but the mom has not aborted the baby. And at that time, then the medical management for that would be a D&C, or where they actually go in and they either can scrape the contents of the uterus out or actually suction the contents out, somewhat like an abortion termination would be. So again, just get kind of familiar with the different types of spontaneous abortion, which I think the wordage helps you a little bit with what's going on. Don't forget about the importance of the psychosocial. Perinatal loss is complex, and the grief is unique to each individual. Some people take it very, very, very hard. And then we have the ectopic pregnancy, which is an abnormal pregnancy. So usually what happens is fertilization takes place within the fallopian tube, and then usually day 6 to 10, the fertilized embryo will go into the uterus and actually attach to the uterine wall. Implantation will occur. With an ectopic pregnancy, though, most of the time, the pregnancy will occur outside the uterus, and most of the time it's going to end up in the tube, where it actually does never come out of the tube, but it stays in there and attaches itself and begins to grow. Now the tube, as you can see, is very small. So once the baby gets too big for that tube, what's going to happen is it's going to burst. And what can happen is then the patient gets really, really sick. The abdomen will get really, really rigid. There's going to be a lot of pain, but the patient can quickly bleed to death because so much blood is going to that area right then and there. There have been cases where patients are feeling some pain and everything else and some bleeding, and they don't seek care. By the time they do call an ambulance, those patients are already they have died of an ectopic pregnancy. So most of the time, we're going to find it's in the fallopian tube, but there have been cases where it's been outside of the uterus and stuff. There was a very interesting case that we had probably about 8 years ago, where they found a pregnancy and it was outside of the uterus, but what wasn't in the tube. And so they encouraged the patient to seek medical attention to end the pregnancy, which she did, and it actually grew, and they actually did a C-section. That little baby boy was born a little bit early and was totally fine. He was actually on the news in Phoenix. But most of the time, you're going to find when we say outside of the uterus, we're talking about the fallopian tube. So the fetus can't survive, and it usually won't develop in most of the cases. So the problem is that, think about this, if that tube does burst, then the doctors will go in, and what they'll do is they'll clip it off. And depending, they can remove it depending on how big it is. But sometimes they can lose that whole fallopian tube. Now, when we talk about losing a tube, there's 2 of them. So they still have one other, but they have an increased risk of another ectopic pregnancy. in the future. Now, this is very scary to patients because fertility is everything to women. And so when they lose one tube, they're so afraid that they might not get pregnant. And it is one of the leading causes of infertility as well. And it's one of the leading causes of maternal mortality in the first trimester, is the bleeding that takes place if they don't catch it early. Now, because we do ultrasounds now very early on, a lot of times we are catching ectopic pregnancies early on when they're very, very small. And so you can tell when they burst, it's an emergency and a possibility of losing a lot of their tube. But if we catch it early on, if it's really small, we can actually give them a drug called methotrexate. Yes, that's what you learned probably in med-surg, the same thing for chemo patients, and actually dissolves the pregnancy with medication, prevents surgery, and prevents them from losing their tube. In addition, sometimes if it's a little bit too large methotrexate, they can just take a piece of the fallopian tube prior to it bursting, which saves the rest of the tube. So some of the signs and symptoms that patients will first experience is maybe some bleeding, some pain, and of course a pregnancy test. And when they come into the hospital, we'll screen them for their HCG levels, and most of the time the diagnosis comes from the transvaginal ultrasound, which can tell that it is a tubal pregnancy. Some of these will actually resolve without any intervention at all. In fact, 68 to 77% will resolve without intervention. We can use medical therapy that I talked about, which is methotrexate, which dissolves this pregnancy by interfering with the DNA synthesis and cell multiplication, dissolves it. It's best, though, we can use medical therapy if the mass is unruptured and measures less than 3.5 centimeters. So we have to catch it early. But it's beneficial because it avoids surgery and it's cost effective. The surgical management, depending on the location and extent of tissue involvement, would include, taking a piece or all of that tube out. Of course, it affects future fertility. Whenever somebody has a tubal pregnancy, we encourage follow-up care, and we also say that they should prevent getting pregnant again for at least 3 cycles, allowing time to heal. Those that do have a tubal pregnancy are at an increased risk for recurrent ectopic pregnancies. And sometimes when we say ectopic, we sometimes interchange it with tubal pregnancy because most of the time it's in the tube. Okay, so we've talked a little bit about miscarriages and abortions and the different types. We've talked about and how that there's a risk for bleeding with miscarriages. We've also talked about ectopic pregnancy and the risk of hemorrhage is real with that. And I would say if I ask most people are quite familiar with miscarriages. Some people are familiar with ectopic pregnancies. But when I ask people if they've heard of a molar pregnancy, most people have not heard of it because it's not as common. A molar pregnancy is a rare mass or growth that forms inside the uterus at the beginning of the pregnancy. And sometimes it's a genetic, maybe like an XXY chromosome with another one. But it results in overproduction of the tissue that's supposed to develop into the placenta. Now, most of these pregnancies are benign, but there are a few cases that can develop into carcinoma. So we pay attention to them. So what happens is they get this molar pregnancy, and if you look at this picture, it doesn't even really look like a pregnancy. But people will take a pregnancy test, they find out their pregnancy, and then when they find out that it's a molar pregnancy, again, there's that psychosocial issue of loss, and they wonder, was that even really a pregnancy? So most of the time, what will happen is they'll have a D&C. But the thing here is that we don't want them to get pregnant right away, at least for 12 months, because we want to monitor that patient to make sure that that molar pregnancy is totally gone and does not develop into choriocarcinoma. So what we do is we make sure they don't get pregnant for at least the next year. And the best way to do that is to put them on birth control pills. And we monitor and one of the reasons is because how we can tell if that molar pregnancy risk returns is by monitoring their HCG levels. And if it begins to rise, then we know that maybe that there's a risk. So the other thing is that if they get pregnant, it's going to interfere with those HCG levels. So the only way we can monitor our patient effectively to make sure it doesn't turn into choriocarcinoma is make sure they don't get pregnant and monitor their HCG levels. Most molar pregnancies will abort spontaneously. We usually can diagnose them through a transvaginal ultrasound and also HCG levels. The treatment would be suction curettage, which is the same basically as for an abortion or a miscarriage, a termination or a miscarriage. Basically, they just suction the contents of the uterus out, or they can actually scrape it out. But again, weekly measurements of HCG levels until they're normal and remain normal are needed. Therefore, we need to take monthly measurements of the HCG for at least 6 months, and follow-up continues for a full year. Therefore, we put them on birth control pills and monitor their HCG levels for almost a year, because a few cases may develop into choriocarcinoma. And if that occurs, then that requires further treatment. Now, if it develops into choriocarcinoma, usually it's we can manage it quite well, but some people actually will end up with a hysterectomy. I had a friend that she actually her and her sister actually worked together. They were both nurses, but the one girl was adopted, and she had always said that she never wanted to, she always felt being adopted, she always, into a family with several children, she always felt like the kind of the odd man out. And so she had a baby, and that was fine. And then her next pregnant, she had a molar pregnancy that turned into choriocarcinoma, and she ended up with a hysterectomy. And she ended up adopting another baby. And she said what she found was that in adopting that second baby, she realized, like being adopted, that that you could love the adopted baby just as much as their own. It kind of resolved that for her. But that was a very trying time for her, because she had the molar pregnancy, and she had, they were monitoring her, and then she had choriocarcinoma, and she actually lost her uterus. But of course, after the hysterectomy, it was resolved. So that's all we're going to talk about as far as early pregnancy bleeding, which was the spontaneous abortions or miscarriages and the different types, ectopic pregnancy, and molar pregnancy. So you need to review those. Now we're going to talk a little bit about the late pregnancy bleeding, which includes placenta previa, placenta abruption, and also DIC, disseminated intravascular coagulopathy. Placenta previa occurs in 1 in 200 pregnancies. Although evidence suggests it's on the rise due to an increasing C-section rate. And the reason is because on a C-section rate, we put a scar on the uterus, which causes abnormal implantation. And an abnormal implantation of the baby would maybe cause placenta previa. Placenta previa is the major complication includes hemorrhage and the development of abnormal placental attachment, which we'll talk about accreta, increta, and percreta. Anybody with preterm placenta previa is prone for preterm birth. Okay, and when we talk about placenta previa, most of the time when implantation occurs, it's going to occur in the upper third of the uterus. Right in here is where the placenta is going to be. You can see here, this is a low-lying placenta, which is almost covering the internal os. Sometimes this occurs in the early pregnancy, and then it will go up a little bit, which will make it safe for the patient. You can see here, though, that this placenta previa is actually covering the internal os or the cervical opening. So basically, in the beginning of the pregnancy, it may not be so much a problem, but as the pregnancy progresses and we get into the last trimester, a lot of these tissues in here are pooled. And so it pools on the placenta, which causes it to bleed. In addition to that, you can tell this patient, if she delivers vaginally, she's going to go right through the placenta, which will cause total hemorrhage for both baby and mom. So she had placenta previa that is covering the internal os, she is going to end up with a C-section. In addition to that, a lot of times in that last trimester when she starts bleeding, she's going to be put into antepartum because sometimes they come into bleeding, it resolves, and they go home and they come back and it starts bleeding. And they're very fearful because they know that they can bleed to death. So how do these patients present? If they came into triage with painless bright red bleeding, so there's no pain, the uterus is not contracting, we would do a transabdominal ultrasound to look for where the placenta is located. If it is a placenta previa, we know that she's going to have a birth by C-section. Now, most of the time, they're going to detect this on ultrasound if they've had prenatal care. But if you have a patient that has no prenatal care and comes in with painless, bright red bleeding, your first thought is going to be, aha, I need to check to see where the placenta is, and you would definitely need an ultrasound for that. The thing you would never do with placenta previa is if you did a vaginal exam on this, your fingers are going to get into the placenta and you're going to have a bloody mess. So nursing intervention would be never do a vaginal exam with somebody with placenta previa, if you know about it, because they've had prenatal care, or somebody who presents themselves to triage without a history telling you where that placenta is. They come in with bright red bleeding, you would definitely want a transabdominal ultrasound to determine where that placenta is. A lot of patients with placenta previa will end up in preterm labor as well. And a lot of times then we have to decide benefits versus risks. So most of the time they're going to be delivering a little bit early. Placenta accreta is when part or the entire part of the placenta invades and is inseparable from the uterine wall. And what happens here is it digs too much into the uterine wall. So then after the patients deliver, the placenta does not want to come out, which causes bleeding and sometimes may even result in a hysterectomy. So accreta is when it extends into the placenta extends into the uterine wall along the normal boundary. And most of the abnormal placenta accretas will be that, 80% of them. But sometimes it not only extends into the uterine wall, but it extends into the uterine myometrium, or the muscle part, 15% of those. And that is a little bit harder because those were probably will not separate after birth, and they'll probably end up having to go into surgery and more likely end up with a hysterectomy. Percreta is the worst of them all because it not only extends into the uterine wall and into the uterine myometrium, but it can adhere to other pelvic organs like the bladder, the GI tract, and other organs. This is very, very, very difficult. So if we can identify this percreta before, it involves an interdisciplinary approach. The one that we had, we didn't know. The problem is we don't exactly know where it's attached to. So when we actually delivered the baby, we had to have somebody there from GI, we had to have somebody there from GU, and other surgeons. And the patient knew that she may not even come out alive because of where it was attached to and the potential for bleed. Both her and baby were fine, but it was a multidisciplinary approach to get that patient and baby out, to get the baby out successfully by saving both baby and mom. We're seeing more of these due to the increased C-section rate, which is one of the reasons why we want to decrease the amount of C-sections. So we have placenta previa, which is an abnormal implantation. And then we have the accreta and the procreta, which are also abnormal placenta implantations. Now we're going to talk a little bit about placenta abruption. And this is where there's a premature separation of the placenta from the lining of the uterus after 20 weeks of gestation. There's a significant risk for maternal and fetal morbidity and mortality. The risk factors include trauma. If you were in a car accident, if a baby fell on your stomach, if the dog fell on you, if you tripped over stairs, any kind of trauma to the abdomen can affect the uterus and pull it away, pull the placenta away from the uterus, causing bleeding. Other risk factors would include hypertensive disorders, cocaine, smoking, twin gestation. All those are the risk factors. What the patient presents in with this is vaginal bleeding and abdominal pain and uterine tenderness, that they're just crying out in pain sometimes, and the patient will be contracting. Now, if we look here, here's a partial separation where the placenta is separating from the uterine wall. Now, in this case, you may not see vaginal bleeding because it's concealed. And I'll tell you about a case I had with this partial separation with a concealed hemorrhage. I had a patient arrive via ambulance. She was screaming in pain. She looked like she was high on some kind of drug, which she was. When they brought her in, the first thing we wanted to do was make sure the baby was okay. So we tried to place the ultrasound on the patient. She grabbed my arm and was screaming because she had such uterine tenderness. When we got fetal heart tones on the baby was in severe distress. She had bradycardia. So we suspected abruption. We rushed her back to the OR due to fetal stress. They opened her up, and her uterus was full of blood because of the concealed abruption. The baby ended up fine, and mom ended up fine too, but she had lost a lot of blood and needed some blood transfusions. And the reason for that one was that the mom had taken some illegal drugs that had caused the abruption. This is when a partial separation with hemorrhage. So you can see how the placenta is separating from the uterine wall, but the blood is coming. This is the patient that, and I'll give you an example of one that I had, came in through the ER, or the triage, was bleeding profusely, was in dire pain, put her on the monitors, extreme uterine tenderness. Baby was in severe distress. We rushed her back to the OR, got the baby out, and everything else. And in that case, it was also a case of mom taking drugs. But it could also have been of a car accident, trauma to the uterus, hypertensive disorders, and other things. And here's a complete separation with a concealed hemorrhage. And you can tell that this would be a medical emergency because both baby and mom will bleed to death in an abruption. There are some cases where you have a small abruption and we just keep them on bed rest and we watch them really closely, and they will heal over. And DIC, most of you in med-surg or sometime in your nursing education has talked about DIC, which is disseminated intravascular coagulopathy. I'm having trouble with that word today. It's a pathological form of clotting. Basically, you know that the clotting is a cascade of events, okay, to stop the patient from bleeding. But DIC is when they're bleeding so much, then they're losing all their blood clotting factors that they can't clot. And so they can bleed to death rather easily. DIC can occur most commonly in placenta abruption and also a retained dead fetus. I'm going to give you an example of DIC. I had a friend that I grew up with, and she was 38 weeks pregnant. And she was driving and her husband was the passenger. She was right behind a car, and the car in front of her stopped. It was a truck. And she attempted to put on the brake, but her sandal got caught somehow, and she couldn't hit the brakes. So she wouldn't hit the car in front of her. She swerved to her left and hit oncoming traffic. It was a head-on collision. Her husband had a severe leg break, and my friend actually, her baby died, and she died. And what happened was she had an abruption, and she bled so much and so fast that she went into DIC, and that's what killed her. So it can be, it doesn't take long for somebody to bleed to death in those circumstances. So those are some of the high-risk pregnancies that we talked about. And now we're going to talk a little bit about, people that come in and they require surgery during pregnancy. Maybe they have appendicitis or gallstones, and I can guarantee if they've got problems with the gallbladder, they're going to probably treat during the pregnancy and try to avoid surgery, but there are some cases where they may need surgery. And in these cases, sometimes me as a labor and delivery nurse will be called to the OR to monitor the baby during the operation. So basically, if an operation is needed, they will do it. Their biggest risk factor after surgery that we watch for is that they don't go into preterm labor because they may start contracting. And then there's all the other complications of, bleeding and infection and other things. But we watch them very closely to make sure they don't go into preterm labor as well. And that the baby does okay because of the anesthesia and stuff. But again, we would monitor them after surgery if they're past 20 weeks. We'll monitor them for making sure the baby's okay and that they're not contracting. Trauma occurs in about 5 to 15% of all pregnancies. Most of them could be a motor vehicle accident. Partner violence, you would think that it would be decreased during pregnancy, but actually our patients are at an increased risk for partner violence during pregnancy. If they do have trauma, they're at risk for preterm labor and placental abruption. So anybody who's had any type of trauma, whether it's falling on their stomach, motor vehicle accident, falling off a bike, a kid jumping on them, or whatever, if they come into triage, our protocol is to monitor them for at least 4 hours, both fetal heart tones and contractions, because we want to make sure baby's okay, and we want to monitor contractions. And we also want to do an ultrasound of the baby, but mostly looking at the placenta, because what we're concerned about is placenta abruption. We'll also do labs to make sure that there was no internal bleeding as well, and that her H&H is okay and everything else. If the patient is Rh negative, we will give them RhoGAM just in case there was a chance that the blood mixed as well. So most people that have experienced any kind of trauma will be in triage being monitored for at least 4 hours. If after 4 hours they are contracting or we are concerned, they'll be admitted for an observation stay. Other high-risk pre-existing conditions that we talked about, those kinds of conditions that people come into the pregnancy with. We already talked about pregestational diabetes, but people come in with thyroid disorders, cardiovascular disorders, anemia, which is a common affecting 20 to 60% of pregnant women also, sickle cell anemia, asthma, systemic lupus, substance abuse. All these people come into, and then we have to manage those conditions during their pregnancy. Substance abuse is huge. For those of you who did get the opportunity to go into NICU, you notice that we have the NAS units, neonatal abstinent substance units. Babies can be withdrawing from alcohol. We have fetal alcohol patients abuse alcohol, which can lead to fetal alcohol syndrome. They can abuse drugs, smoking. We do have substance abuse programs, and methadone is the standard treatment for heroin or narcotics. Every patient has individualized treatment, but we do have substance abuse programs. It is very hard when we see what happens to the babies and everything else, and to be a little bit angry at the patient. But remember that substance abuse is an illness, and we must treat with patience and we must treat with kindness. A lot of people think that those that take substance or do substance abuse during the pregnancy should be punished for that. But just remember, if we punish the mom for that, they're not going to seek treatment in the hospital, and the babies and the moms will be at increased risk for bad outcomes. So right now, what happens if they are suspected of substance abuse? We will check, to see if the mom has taken drugs during her pregnancy, and then social services is called. Sometimes the babies are taken away or given to families to care for the babies until mom can show us that she's taking care of her substance abuse program. And sometimes the babies are taken away, but social services gets involved with what happens then. But the mom can't leave the hospital without getting, in trouble with the law, but she may not leave with her baby. So that ends the high risk section of our lectures. So be sure to look over this. There's a lot, but check your book and some other resources. If you have any questions, we'll talk about this during our class time. So thank you and have a nice day.